Next, about the arterial supply, uterus is supplied by uterine artery, which is partly by the ovarian arteries. So uterine artery, it is a branch of anterior division of internal iliac artery, which runs medially across the floor. So you can see this is the internal iliac artery. It is internal iliac artery. This is the anterior division. From the anterior division, we see the origin of uterine artery, which is running in the base of the broad ligament. So runs in the base towards the uterine cervix. It passes superiorly to the ureter, then it goes till the ureters, which are present in front or near the upper part of the uterus, and superior lateral to the fornix of the vagina. Then it ascends along the lateral side of the uterus, and as the superolateral angle of the uterus it reaches, it turns laterally and crosses the uterine tube and anastomoses with the ovarian artery. So we can see the anastomosis between the uterine artery with the ovarian artery. So uterine artery supplies vagina here. We can see as the vaginal arteries, and also part of vagina it supplies. Then it supplies the uterus, medial 2/3 of the uterine tube. It also supplies a little part of uterine tube as well before its anastomosis, and medial 2/3, and also it supplies the ovary, and it supplies the ureter and also the structures within the broad ligament of uterus. So branches near the cervix, after crossing the ureter, it gives the ureteric branches. So after crossing the ureter, it gives rise to ureteric branches, and it gives rise to vaginal branches. You can see one vaginal branch going down, vaginal branches, cervical branches to the cervix. The cervical branches form a circular anastomosis around the isthmus of the uterus, and along the side of the body of the uterus it gives off some arcuate branches. Here we can see the uterine artery on each side within the broad ligament, dividing into arcuate arteries. You can see on each side, anterior and posterior, which further gives rise to radial arteries. We can see here radial arteries, and they divide to form stratum vesiculare within the wall of the uterus. So from the stratum vesiculare, the basal and the spiral arteries are given off to supply the endometrium, and spiral arteries supply the functional zone of the endometrium, which is the casting off during menstruation, and basal arteries supply the basal zone of the endometrium, which supply the supplies in regeneration of denuded endometrium. Venous drainage of the uterus is mainly into the internal iliac veins. We can see it drains into internal iliac veins, which finally drains into the inferior vena cava. So internal iliac veins drains into common iliac veins. Common iliac veins joins to form the inferior vena cava. So we can see the plexus, right uterine plexus and left uterine plexus, forming right uterine artery and left uterine arteries. Next, about the lymphatic drainage, the fundus and the upper part of the body drains into pre and para aortic lymph nodes. We can see here the fundus and upper part of the body drains into para aortic or lateral aortic lymph nodes or pre aortic lymph nodes, which are along these lymphatics travel along the ovarian vessels and along the round ligament of the uterus and drain into, and here the lateral part and the angles of the uterus which travel along the round ligament of the uterus and drain into superficial inguinal lymph nodes, which are external or superficial inguinal lymph nodes on each side. And middle part of the body, the middle part of the body, we can see the middle part of the body, which drains into internal iliac lymph nodes, which are along with the internal iliac artery. So from the cervix on each side, the vessels drain into three directions: laterally external iliac and obturator nodes, posterolaterally internal iliac nodes, which are the major drainage, and posteriorly to the sacral nodes. So that is about the lymphatic drainage of uterus. Next, regarding the nerve supply of the uterus, the nerve supply of the uterus is predominantly from the inferior hypogastric plexus. So here we can see inferior hypogastric plexus. These are the inferior hypogastric plexus which supply the uterus and which are carried along the uterine vessels, that is uterine and ovarian arteries, and these nerves ascend with the along the broad ligament along the uterine vessels and connect with the tubal nerves to form the ovarian plexus. So they form the tubal nerves to form the ovarian plexus near the ovaries. The nerve to the cervix is from the plexus that contains a small precervical ganglion. So they are paracervical ganglion, or on each side of the cervix they are present. So they are called paracervical ganglion. And sympathetic preganglionic fibers are derived from T10 to T12 and L1 to L2. So you can see the preganglionic fibers from T10 to T12 and also L1 and L2 gives rise to sympathetic preganglionic efferent fibers, and they are the last thoracic and first lumbar spinal segments with synapse on the postganglionic neurons in the superior and inferior hypogastric plexus. These fibers produce the uterine contraction in non-pregnant uterus, and vasoconstriction, that is the uterine contraction in pregnant uterus, is under oxytocin hormone. So it is not due because of nerves, it is mainly because of oxytocin. So the contraction during pregnancy is due to oxytocin hormone, and in non-pregnant women the contraction is due to the sympathetic preganglionic nerves, that is which are derived from T10 to T12 and L1 to L2, and they are also help in vasoconstriction. So sympathetic preganglionic also causes vasoconstriction. Next, about the parasympathetic preganglionic. Parasympathetic preganglionic arise from S2, S3, S4. So we can see here sacral nerves which are the parasympathetic. So S2 to S4 and relay in the paracervical ganglion, and they cause uterine inhibition and vasodilatation. So they cause uterine inhibition in contraction and vasodilatation, but these activities are complicated by hormonal control for uterine functions. So most afferent sensory fibers from the uterus ascend through the inferior hypogastric plexus and enter the spinal cord through lumbar splanchnic nerves, that is to T10 to T12 and L1 to L2, and along with the corresponding spinal nerves. Coming to the sensory supply, the sensory supply to the cervix and upper part of the birth canal pass through the pelvic splanchnic nerves, which is called as nerva erigentis. The root value of the sensory nerve is S2, S3, S4. And those from the lower portion of the birth canal are primarily supplied by the pudendal nerve. We can see the pudendal nerve which supplies the lower part of the birth canal. So pain during the first stage of labor is initially confined to T11 to T12 dermatomes. So if you see the dermatomal distribution during the pain of first stage of labor, it is because of T11 to T12 dermatomes, that is called as latent phase. but eventually the labor when it enters the active phase, and much of the pain is due to the dilatation of the cervix and lower uterine segments, and pain through the hypogastric plexus and aortic plexus before entering the spinal cord at T10 and L1 nerve roots. So stretching and compression of the pelvic and perineal structures involve the pudendal nerve with the root value of S2 to S4. And so pain during the second phase of labor involves T10 to S4 dermatomes. So first stage of labor only T1 to L1, second stage of labor both from T1 to L1 and S2 to S4 dermatomes are involved, causing severe pain during second phase of labor. That is latent phase, where the hypogastric and aortic plexus are convey the impulses. During second phase, pudendal nerve, so the T1 to S4, all segments of dermatomes are involved. So this is the thing which has to be noted. The clinical aspects, the spinal anesthesia up to the spinal nerves T10 is necessary to block the pain for the vaginal delivery, and up to the spinal nerves of T4 is cesarean during cesarean section. So the blocking of the nerves till T10 is during vaginal delivery, and blocking of the nerves till T4 for cesarean section due to the sympathetic fiber levels being higher level than the motor and sensory blockage. And lumbar spinal anesthesia, that is the spinal block, in which the anesthetic agent is introduced with a needle into the spinal subarachnoid space, and it anesthetizes the intraperitoneal, subperitoneal and somatic structures, and it produces complete anesthesia inferior to the approximately the waist level. So the perineum, the pelvic floor and the birth canal are anesthetized, and motor and sensory functions are entire lower limbs as well as the sensory. So spinal anesthesia, lumbar spinal block and caudal epidural block and pudendal nerve block. So in caudal epidural block, in which the anesthetic agent is administered during dwelling catheter in the sacral canal, and it anesthetizes the subperitoneal and somatic structures. So the entire birth canal, pelvic floor and most of the peritoneum are anesthetized, but the lower limbs are not usually affected, and the mother is aware of uterine contractions. So let's see some questions associated with the uterus. The following group of lymph nodes receive the lymphatics from the uterus except external iliac, internal iliac, superficial inguinal, deep inguinal. So the lymphatics from the uterus reach the superficial inguinal nodes but not to the deep inguinal nodes. So the answer is deep inguinal. The lymphatics follow the round ligament of the uterus to reach the superficial inguinal lymph nodes. The upper part of the uterus, like fundus, drain into para-aortic and pre-aortic lymph nodes. Lymphatics from the cervix spread towards the external iliac as well as internal iliac lymph nodes. So that is about the lymphatic drainage. So this completes the anatomy of uterus along with its clinical aspects. Thank you.